Welcome to our Thursday morning didactics. We're coming to you from our Corewell Health conference room today, and so honored to have some members of our interdisciplinary faculty present to everyone today. This is a didactic session that they gave to our team during one of the days in September last year when I think other programs had other things going on, and I thought this is so impactful, and we really should have everybody be hearing this content. So we're thankful to have, we have Tori Hildreth, who is one of our social workers on faculty, Molly Dollahan, another one of our social workers, Natash Kaminsky is one of our chaplains on our team. And so they'll be leading us in this topic and discussion. And we encourage you to utilize the chat, put in comments, questions that we can monitor throughout the time here, and look forward to any questions also at the end too. But feel free during the time to use the chat function, and and if you have any, for some reason, if there's any audio issues or things that come up on your end, please let us know so we can adjust. So I will turn it over to Tori.
Yes, can everyone hear me okay?
Assume we're still good.
Okay. Well, good morning. My name is Tori, just like Dr. O mentioned, and we are very excited to be able to share this presentation on health equity from an interdisciplinary discussion. I was a part of the interdisciplinary team here for Corewell Health on the Palliative Care team. We see health equity every single day. We advocate for it. So why not have a great discussion and a didactic on it? And just a little bit of background, I joined the Palliative team about 3 years ago. And as soon as I joined the team, there was a 33-year-old patient who lit a fuel underneath me when it comes to health equity. And because of her, I have spearheaded and I have tried to advocate dangerously for all of our patients. And I'm very thankful to be able to do it with our team and our other social workers, chaplains, and nurses from the Palliative team. And so I have with me this morning Molly Dollahan and Natash Kaminsky, who will be giving a presentation after some definitions of equity. So let's get started. First, we need to understand health equity. What is equity? So equity is the absence of unfair, avoidable, and remediable differences among groups of people. You'll see in this diagram here, it breaks things down as far as inequality, equality, justice, and equity. The diagram shows you the dramatic differences between the four and why we should strive for equity in every case. Whether these groups of people are defined socially, economically, demographically, or geographically, they should have the ability to receive full potential for their health and well-being. Health is a fundamental human right, and everyone deserves to have health equity. So regardless of their class, regardless of what they're born into, they deserve this right to reach their best goal. And you'll see equity in the bottom right corner, where we custom tools that need to be identified by each person in each person's situation. So then thinking of health equity with the state and city levels at mind, the CDC created this awesome diagram along with the World Health Organization and public sectors to identify how can we capture health equity and how can we measure it to ensure that every single person has equitable health. The 6 categories here are broken down into race, sexual orientation, gender identity, ethnicity, preferred language, and disability status. Over the years, health equity has generally been underreported because there is a lack of standardization and collecting this information. There's also been limited reporting on what is happening in different communities as well as different healthcare systems because they're not collecting this data efficiently. Within the last 4 to 5 years, health equity data has been captured tenfold, and we've been able to see where we all need to improve as a system, state, as well as local levels. Better collection of this data as well is going to help us understand where we need to improve as a system, whether it's a healthcare system, state, city, or federal levels. These initiatives are also going to help reduce health disparities and help improve overall health. And you'll see each category has different explanations as far as what's captured and what they're looking for. Now that we understand health equity, let's talk about social equity. Social equity is the impartiality, fairness, and justice for all people in social policy. Social equity considers systemic inequalities to ensure that everyone in a community has access to the same opportunities and outcome. Equity of all kinds acknowledges that inequity exists and we need to work to eliminate them. In this diagram, you will see the 7 main drivers and interventions that promote social equity: culture, understanding community, legal compliance, equipping staff and stakeholders, equity champions, diversity and inclusion, practice, and culture. When we think of culture, we think of an organization needs to focus on equity champions, admitting to past inequities, creating a foundation of trust, building integrity, and having an open dialogue of equity. Then when we think of the community level and understanding our community, we need to ask questions such as, what are our communities doing? What are our community demographics? What are historical and ongoing disparities that our communities face? And what's the importance of action, and how can we start that today? Then when I think of diversity inclusion, we think of honest and true inclusion, fair personnel practices in different healthcare organizations on state and local levels, as well as we want to promote equity within both the administration as a whole, as well as the service delivery and those who are face-to-face with our community. And lastly, and what I feel personally is the most important, is practice. We need to reduce the barriers to our employees by understanding that equitable decisions need to be taken every day. Then we need to find a rewarding way to reward that decision and continue to make that choice for every patient. Now we think of determinants of equity, and this is one of my favorite graphs, because when you look at this graph, think of the tree as a new patient you're consulted on. You can see that you can see how they present, but we don't know the underneath. We don't know what's going on in their life, what's shaped their health to bring them to the hospital. The conditions in which people live, work, and play are determinants of equity. You'll see here underneath the tree, there's different ideas of the determinants of equity: affordable and safe quality housing, access to parks and natural resources, or family wage jobs and job training. Equal opportunity in these areas is very much necessary for all people to thrive and achieve their full potential, regardless of race, income, or language spoken. Now we go to health inequities. Health inequity refers to the avoidable differences in health groups between different groups of people. In this analysis here by the American Community Survey, it highlights the health disparities driven by social and economic inequalities. It does a great job at not only breaking down the barriers, but also seeing how they can all play a role together. Economic and political systems can influence poverty. People born in areas where poverty is high may have reduced access to clean water, safe housing, healthy food, or education, which all impact health. This creates an avoidable and an unfair divide between different groups. Today, changes in government policy are necessary to overcome this. This is on a systemic level. Health inequity, refers to not only the local, national, but also a global scale. This happens in all countries. And these widespread differences just overall result in an unfair system, setting people up at a different disadvantage. So now we talked about health inequities. We need to now talk about structural inequities. Structural inequities describe the disparity in wealth, resources, and other outcomes that result from discriminatory practices. And we look at this diagram here. It identifies that members of an interconnected social category and those that are also connected to the systems, and structured power equal structural inequity. Discriminatory practices of all institutes, such as legal, educational, business and government, and healthcare systems. When we think of structural inequity, there are 6 main structures to keep in mind: education, housing, healthcare, race, gender, and media. Structural inequities, educational structural inequities, reference students in low-income neighborhoods that often receive inferior education compared to those that are attending an out-of-pocket private school. Then when we think of a housing structural inequity, think of the systemic segregation through zoning. And by zoning, I refer to the amenities like green space or large spaces in wealthy neighborhoods. However, you'll notice there's not that same capability and there's not that same feature created in lower income communities. Instead, these areas are packed with tight apartment complexes that are often very small, Section 8 housing neighborhoods that often get negatively labeled, as well as they lead to higher crime rates. When thinking about race, think of the racial gap that still exists in housing. Poor neighborhoods are often less safe, schools have lower qualities and lower funding from the state and city levels as well. And then the most important one that often is in the media, is in the social media, as well as discussed often on the news, is gender. There are structural gender inequities and biases that are still in the workplace among women versus men, such as leadership roles, high-level responsibilities, and there are ongoing income disparities. So thinking of structural inequities, how can we improve this? I think this is an awesome diagram that just shows overall what are the biases, the economic and political drivers that contribute to structural inequities. This diagram is created by the National Academics of Science, Engineering, and Medicine. Their scholarly work surrounded the root of health inequity. The outermost circle in the background here indicates the context in which health inequities exist. Structural inequities encompass policy, law, governance, culture, and refer to race, ethnicity, gender identity, class, and sexual orientation. And as we know, these inequities produce systematic disadvantages, which lead to inequitable situations and experiences that impact social determinants of health. So in the outer circle, we'll see things like transportation, education, housing, and income. All of these social determinants of health are impacting the community on a personal level, as well as how individuals are able to live, learn, work, and play. In the innermost diagram with the colors here, it talks about how making health equity a shared vision and value will systematically move things forward. We need to make sure that we're collaborating on the community, state, and city levels, because policy is going to play a huge role in these changes. You'll see I love diagrams. So here's another one, social determinants of health, which is one of the main things that I discuss and I encounter with every patient. The United States Department of Health and Human Services defines social determinants of health as a condition in which the environments where people play, are born and live, work and worship, and age that affects a wide range of health functions and quality of life outcomes. The more we engage with our patients, the more we can understand what their wheel is of social determinants of health. From a documentation or a medical standpoint, you may see the acronym SDOH, which is something that I have personally seen more frequently in documentation of patient care. Not only do we want to know why someone has cirrhosis, why someone has a new cardiology diagnosis or any type of heart-related issues, we want to know how this has impacted their health. Then we want to know what are their social determinants of health, what impacts their ability to care for themselves day to day, to take care of their health, to feel safe in their own community, in their own home. Do they have the social support? Are they discriminated when they go to an emergency room based on their insurance? There are many pieces of social determinants of health that impact overall health. And it's our goal as clinicians to understand the background of our patients, those roots of the tree from the earlier slide. We need to be able to partner with our patient and their families to support improving the barriers to their health and wellness so they can achieve the best health possible. So now that we have an understanding and a definition on health inequity, social inequity, structural inequities, I think it's very important for us to understand the status of disparities that are happening today in our own backyard here in Michigan. And the first here I'm going to share is Michigan's maternal and infant health. This data comes from the 2022 March of Dimes report card, which actually highlights the key measures on disparity in maternal and infant health. So let's first look at the diagram here on the right of Michigan. Excuse me, the left. The diagram on the left shows something called a maternal vulnerability index for the state of Michigan here, because where you live matters and impacts your health. This index is actually the first county level and national scale tool to identify where and why moms in the United States are vulnerable to poor pregnancy outcomes, as well as pregnancy-related deaths. Differences in these counties are measured in 6 different themes: reproductive health, physical health, mental health and substance abuse, general health care, socioeconomic determinants, and physical environment. And you'll see here on the left, the darker the color, the higher the score. The higher the score indicates a greater vulnerability to adverse maternal outcomes. Take a look at your county. Why do you think certain counties have a higher vulnerability than others? Then we look at the right. This diagram on the right shows preterm birth rates by race and ethnicity here in Michigan. And you'll see that in Michigan, the preterm birth rate among Black women is 59% higher than the rate among other women. I am very thankful that we have measurable data to capture this, to know how and where we need to improve on a community level, as well as when it comes to overall health equity. So now let's look at another status of the disparities today. The CDC has a behavioral risk factor surveillance system. This system created this document here. The system can identify high blood pressures by race, ethnicity on the state and federal levels. You'll see that the state of Michigan has a higher amount of blood pressure diagnoses than the majority of the United States for the following populations: Black, multicultural, other race, and whites. Whereas Asians, American Indians, Alaskan Natives, and Hispanics are far less diagnosed than those populations in the United States. It has us thinking, what can cause one population to have a higher blood pressure diagnosis? Think of their environment, their access to food, their income. That determines also what food they will buy and what they can afford. There is such an impact on health. Now, by that same company, by that same CDC risk factor surveillance system, they also broke it down by income. And this study continues to show the state of Michigan as well as the federal levels. With this data, you will see that the state of Michigan has higher blood pressure diagnoses for lower income families than those with higher income, which continuously showcase how income truly does impact overall health. Now let's talk about another very important topic that we may encounter when we meet our patients that we're consulted on, those that are uninsured. This analysis by the American Community Survey identifies the uninsured rates for non-elderly populations by race and ethnicity. Despite large gains in coverage of insurance, and since the implementation of the Patient Protection and Affordable Care Act in 2014, people of color and other marginalized and underserved groups remain more likely to be uninsured. Racial disparities in coverage has persisted continuously. This data shows that the higher uninsured rates for non-elderly American Indians, Alaskan Natives, Hispanics and Blacks, Native Hawaiians, and Pacific Islanders are at higher disadvantages of having uninsured than their white counterparts. Other groups also remain an increased risk of being uninsured, thinking of our patients that are immigrants and people in lower income communities. Many people who are uninsured are eligible for coverage through Medicaid or different marketplaces. However, they still face barriers to enrollment, such as confusion of the system or eligibility policies, difficulty navigating enrollment processes, language barriers, or literacy problems. Some immigrant families also have immigration-related fears that are a barrier for them to feel comfortable to enroll themselves or even their children. Others remain ineligible because of their state did not expand Medicaid, or that there is a 5 to 6 year wait through immigration and citizenship before having the right to insurance. And this goes back to my very first point about health equity. Healthcare is something that should be accessible for everyone, regardless of their income, status. It is something that frustrates me here in 2023 that we are still facing this, that our patients are still having a barrier to their care because of the systemic injustices, the systemic inequities. There are things that we can do today that can make a difference here with our patients, understanding those roots of the trees, and making sure that overall we are advocating for those that do not have a voice or that do not feel safe enough to use their voice. And these are only 4 data slides. There are many slides that show the continued injustices throughout the system. Now I want to pivot to a very important health equity case example. I think it's important not only to discuss the educational aspect of definitions, to see the data and the literature on it, but to then also be able to apply it in real time and to see how the real cases we face, the new patients we meet, our follow-up patients, I think it's important to discuss their equity in the cases that we've encountered. I'm going to pass the torch here to my colleague, Molly Dollahan, who's experienced many, many different health equity cases that she has advocated dangerously for as well.
Good morning. Thank you, Tori. I really appreciate the opportunity to share this example with you today. And just a preface to protect the anonymity of the patients. Clearly, we've removed any HIPAA identifiers, and I'll be referring to a number of different health systems, and I'm simply just going to refer to them as A, B, C, and D. I've worked in a number of different health systems throughout the Midwest over the past 20 plus years, and this is one case example that will probably stay with me until I retire, in terms of just how eye-opening it was for me as a social worker. And I would just encourage you, as I kind of rapidly go through this example, to think about those social determinants of health that Tori just shared, and try to filter the information through those different types of determinants. So I had the honor to meet a 28-year-old female who came to us from Mexico. She had been working in the United States as a farm worker, a migrant farm worker, for several months, about 6 months, I think, when I first met this individual. She at first, her medical issue first started to show as pain in an ankle. She's certainly someone that works in a very physical job. She presented to an ER in Georgia, where it was thought that it may be a sprain. And it sounded like she'd had this pain, this issue for about 6 months. Through the course of her farm work, she did end up in a state here in the Midwest, where she presented again to another emergency room, I'll just call it Hospital A, where she was unable to bear any weight. Labs were concerning. She was sent for an advanced imaging and MRI, and was found to have an osseous destructive mass. Bones were breaking in her foot because of the mass. That was in, I'll say, April. So she presented to the ED in Georgia in March. She presented to Hospital A in April. And then in June, she presented to, or she was referred to Hospital System B to be seen by an ortho-onc service who needed to do a biopsy. And if you want to go ahead and show that slide, Tori. When I met this patient, I, at the time, was in this Hospital System B, and just started looking through the chart and, noticed that the particular ortho-onc department was having some difficulty reaching the patient. And in looking at the notes, noticed some things such as this ortho-onc team had not been able to reach the patient, and come to find out that they had been calling, and I think also she had also been referred to an interventional radiology service with this hospital system. But what I realized in looking through the chart is that the patient wasn't calling providers back because all of the options were in English on the phone system. Mm-hmm. And this patient did not read, write, or speak English, and would be receiving calls to come in and get a biopsy, but wasn't calling back. This patient was incredibly smart and knew that there was a Spanish-speaking nurse with her primary care doctor office, and whenever she would be getting calls that she didn't understand, she would reach out to this primary care doctor office, which had like a rural outreach program to migrant farm workers in this very rural area. And she would call this nurse and say, I don't know who's calling me. This is the phone number. I have no idea what they're saying. Mm-hmm. That particular nurse would then initiate like a three-way call using an interpreter to these other hospital systems to get her this critical medical care that she needed. This occurred many, many times in just simply helping this patient navigate the differences between ortho-oncology, interventional radiology, etc. She eventually did get the biopsy so the ortho-onc team was with Hospital System B, her PCP is with Hospital System A, had the biopsy done with interventional radiology with Hospital System B. And then I think you'll see on the bottom of the sheet, there was another call where, she was contacting again the PCP because the biopsy site was bleeding so heavily. It was bleeding through her pants, like through the dressings to her pants. Again, utilizing three-way interpreters through her PCP office, because the discharge instructions that had been given her after the biopsy were all in English. So, this patient was not able to really fully understand how to properly care for the site or what the warning signs would be. Actually, not that one quite yet. Or what the warning signs would be, because all the information was in English. I noticed here that the patient was advised to put gauze and Band-Aid on, apply pressure, elevate when possible, take it easy, etc. One thing I did wonder when I was reading that is if the patient does not have a car and is living at a rural farm, does that patient have access to gauze, purchasing Band-Aids, getting to a pharmacy to get these items, etc. So that was in June, and the biopsy results showed clear cell sarcoma. She was referred to, so her PCP with System A collaborated with System B, and the decision was made to refer this patient to a university, which was about 3 hours away, to go to a sarcoma clinic, certainly very appropriate referral, very rare cancer. The patient knew someone who had a vehicle that got her there, and oral chemo was discussed at this hospital system C, I'll call it C as in cat. And then later that month in August, the patient was hospitalized for 24 hours at hospital system B with a worsening cough and due to bilateral pleural effusions, sent back home. A little bit later in that month, the patient was hospitalized again at hospital system B. This time more imaging was done, PET scans were done, etc. It was discovered that the patient never got the oral chemo med. And the patient has stated at that hospitalization that she did not know where the chemo med had been sent. And the imaging showed progression, disease, progression to the lungs, the pleura, the lymph nodes, soft tissue, right femur, left tibia. Patient had a right pneumo, bilateral pleural effusions, and innumerable pulmonary mets. During this hospitalization, it was learned that the oral chemo med had been sent to what I'll call System D as in dog, which was a private oncology office. And at this time, not all of these different hospital systems utilize the same electronic medical record. And not all providers could see other providers' notes. A consult went into palliative care for goals of care as this patient had a very, she was hospice appropriate. We qualify for hospice with a diagnosis of 6 months or less. And some things I learned while serving as her social worker, and thinking back to all the discharge instructions that were given, like take it easy, rest, elevate. She shared with me that when you're a migrant farm worker, your housing is owned by the farmer. Your housing is owned by your employer. And if you are not working, you have no place to live. So she couldn't take time off. The other, she had, I think, one sibling that had traveled with her, that was with her. If you're working as a migrant farm worker, you don't have access to things like short-term disability, FMLA, and you don't have the privilege of others being able to take time off from work to help care for you, because they can't stop working either. They will lose their housing as well. And she even shared too, it was very difficult from a privacy standpoint, because you're in like a shared room with shared bunk beds, and just a lot of concern about even her privacy regarding her medical condition. She didn't feel ready to tell her family in Mexico yet that she was dying. And how do you hide the fact that you have this medical condition when you're living in a setting that's communal? This patient, because she was visiting in the U.S., on a work visa, she had emergency Medicaid only. And one thing I want to make really clear about emergency Medicaid is that covers the hospitalization only. It does not cover any of her outpatient appointments. So that does not cover getting a biopsy. It does not cover imaging as an outpatient. It does not cover any medications as an outpatient. It only covers when the patient is in the hospital. So to date, just simply getting this diagnostic workup, that's all out of pocket. The oral chemo med is out of pocket. So in the course of this hospitalization, I would say, I'm just guessing, I met her, say, on a Tuesday. Goals of care was completed. She made it very clear, look, I understand I have a very poor prognosis. What matters most to me is to get home and see my parents before I die. And so we kicked off a plan high year to get all hands on deck and figure out how can we support this patient in what matters most, to get this patient home, to die at home with her family. So this is another part that was pretty eye-opening to me. I worked very closely with care management and multiple other disciplines in the hospital. And one thing we wanted to do was give her, and the patient was asking for copies of her records, because it would be quite a long trip from Michigan back to, this was southern Mexico. And at this point, she was on oxygen, was not ambulatory, in a wheelchair. We spoke with medical records, spoke with translation and interpretation services, and learned that it would take probably 2 weeks to be able to translate a 2-paragraph summary. You think of like a discharge summary, to travel with her, because we didn't know, like, if she were to decline en route, maybe she would have to stop and go to Texas, or once she gets to Mexico, would she need to go directly to the hospital? Could we have something that she could take with her? And we learned that we couldn't do the discharge summary on the date of discharge. That would be the most up to date. So one of our physicians very kindly wrote up a two-paragraph summary of everything we knew as of that moment. And I submitted it immediately, knowing it would take a week to get it translated. We did get that and sent that with her. We learned that we could not translate the discharge instructions in advance. And I want to point out the difference between interpretation services and translation services. Interpretation is oral, translation is written. She needed an oxygen concentrator. This is not covered under emergency Medicaid. That is an outpatient DME. We reached out to, a DME, everyone would know the name. They found a refurbished oxygen concentrator and donated that. And in the course of preparing for her to go, the family made the point. Family was so sharp and so proactive, and they said, well, we only have 2-prong plug. This is a 3-prong plug. And we learned that the DME company doesn't provide that. So I talked with the care manager, and essentially the care manager went to Lowe's on the way home and picked up an adapter out of her own pocket and brought that in the next day. Now, thinking back on all of the pitfalls of, I kept seeing in the chart and hearing that, the patient needed to call the PCP that had the one Spanish-speaking nurse to understand what the discharge instructions said of all these places she had been before in all these different hospital systems. And it really bothered me, like, why is this so complicated? Why does this patient still keep getting instructions in English? Like, how can we improve upon this? And at this particular system where I was working at the time, I just said to the nurse, show me what it looks like. Show me what this patient will be given. And so as we were approaching, I think it was like the day of discharge or the day before, I asked her to show me, because I kept hearing you push a button and then the electronic medical record will produce the discharge instructions in Spanish. So at this particular time, this particular medical record, this is what it produced. And it may be difficult to see, because I know some of this is small, but I'll just highlight a few things. The first part in Spanish, it says, tome estos medicamentos en su horario indicado. Take your medications according to this schedule. The schedule is in English. The oral chemomed instructions are in English. The Senna is in Spanish. The morphine is in English. So this particular EMR system, many hospitals have very different EMR systems. This particular one at this moment in time, this was the best it could do. And in thinking about this too, not every language is programmed into this system. I mean, how many languages are there in the world? Like, there's just, it isn't a perfect system as much as we want it to be. And then we're right back where we started. With the lower right-hand corner, you can see the discharge instructions for this particular, interventional radiology. This patient had a thoracentesis right before, I think it may have even been the day before the day that she left. We tried to optimize her as much as possible prior to this trip. So here, once again, the instructions are in English, and I was told that that's the way the computer prints them. It can't print everything, uniformly. So the workaround was basically to fill in the gaps where computers just can't do it perfectly, would be to have an oral interpreter present. So we got an in-person interpreter. Because of the time that is involved to translate written all of this, and in translating does take, it's a very time-consuming process. The workaround is basically to have an in-person interpreter, and it will be the patient's responsibility to take notes in their native language. Fortunately, in this case, the patient and her peers all all wrote and read Spanish. So they were able to take detailed notes as the in-person interpreter went through this line by line by line with the patient and family. But that made me think about other patients I've had where they do not read or write in their own native language. So there's just, it gets very complex very quick. Let's look at the next page. So again, this particular computer system at this moment in time, this was the best they could do in terms of Spanish discharge instructions for somebody leaving with an oxygen concentrator. What do you notice in this picture? What I notice is that's not an oxygen concentrator, that is a tank.
Yep.
I had the opportunity to live in Mexico as an exchange student many, many years ago, and I know when, living in a country where your first language isn't spoken, you rely a lot on pictures. And I remember it was stressful just to find the bus stop or read the bus schedule to get to school. I can't imagine looking for pictures because I'm fighting for my life. But this is what the computer prints. So thankfully, again, at this moment in time, we had access to an in-person interpreter who came and was there in person with the respiratory therapist, and they went over all the buttons, all the dials, everything on the oxygen concentrator. We managed to get the manual for that oxygen concentrator in Spanish, and that was sent with the patient as well. I'm going to speak really quickly here because I want to give time to my colleague, Natasha. The patient's medications were sent to the pharmacy at this hospital, which is privately owned. So it's, a company out there like any retail pharmacy name you've heard. It was not owned by the health system. And they cannot print medication labels on bottles in Spanish. The patient had asked, can I get my pill bottle labels in Spanish? And the particular pharmacy attached to the hospital did not have the ability to do that. Also learned and so none of the opioids, and the hospital can help pay for medications at discharge through like something called a care fund, but they cannot cover opioids. They cannot cover any controlled substances. Fortunately, the patient and her friends, pooled monies together to be able to purchase that. Also, we learned at the last minute, the pharmacy was out of morphine. So they automatically sent the prescription to an outside pharmacy, which was over 45 minutes away, which was where it was in stock. Fortunately, this patient had access to a car through a friend, but this also took place, I don't know, like at 6 or 7 at night, and the buses don't run to that location. So if this patient didn't have access to a car, there's no way they would have gotten there at night in the dark. So it just was kind of one thing after another after another. That is the long and short of my experience with that case. And, there was a lot of effort expended to make sure this patient had a safe discharge and get home. But I think, I just kept picturing, Tori had shared that picture of the ladder in the tree. And sometimes it takes a lot of work for that ladder to be built. And a lot of energy, a lot of blood, sweat, and tears. And it took a lot of time to build all the steps on that ladder. And I'm going to just end real quickly with a quote that I came across while I was preparing this week. It's a quote that was written actually in 1995. And just think about the many miles that this patient traveled and the many years it's taken to create these electronic medical systems. The quote is this: "We live in a world grown smaller and more interrelated by virtue of travel and technology, but with increased divisions of wealth and poverty." Say it one last time. We live in a world grown smaller and more interrelated by virtue of travel and technology, with increased divisions of wealth and poverty. Thank you. I'll turn it over to Natasha.
Thank you, Emily. And that's, one case with such social determinants of health and disparities. Thank you. We'll pass the torch to Natasha.
Thank you, Molly. Thank you, Tori. I'm going to talk briefly just about the place of spirituality in this. I think it is important to recognize those aspects of the human experience that can be a little bit harder to quantify, harder to measure, but I think we all can recognize. Spirituality, as I'm sure, most of us who come to this field have some personal sense of spirituality and, deep sense of values and what's important to us that has led us to be on a lecture about health equity at 7:30 in the morning, right? Because on some level, we know this is important. It's important for us, for the patients we serve, for the larger world around us. And, I think when we recognize that everyone around us is making sense of life somehow, and I would say that that's what spirituality is. It's how people are making sense of life. What are the values that guide you? And whether you are overtly religious or not, we all have some system by which we evaluate what matters and what kind of person we want to be, where we want to invest our time and our energy, and how we understand our own sense of purpose and meaning, that we matter too. And some of us, as we've discussed, will probably have had an easier time of feeling and experiencing that based on the circumstances into which we were born. One of the things I think is important to remember is that as we look at the chaplains on your team, they may not, you may not even know what personal spirituality they practice, but I do think it's good to recognize that all of the world's religions, at their pure core, have what many of us would refer to as a preferential option for the poor. This injunction to be in tune to the fact that the world is unjust, that the world is not fair, and it is good for us and for the world and for those individuals who may be in circumstances different from our own to labor to rectify that. That is good. That is good work. And be intimidating, as you know, that the case we just discussed, but it is undeniably good work. You know, the way I think we often observe evidence of spiritual health and well-being in our patients, regardless of what circumstances we meet them in, is their measure of peace. And that can sound a little bit too obvious, but I think there is a way in which our spiritual health, or the fragility of our spiritual system or system of meaning, is revealed when we meet difficult circumstances. Is it that I know how to make sense of difficult things? Or, you know, we often will hear patients say something like, what did I do to deserve this? And I think that that is an understandable question, but one that also is evidence of maybe an underlying belief that one is in control of one's life more than might be true. I hate to tell you, you may not be in complete control of your life. And so when we come alongside folks in their time of distress, of suffering, challenge, change, using your chaplains, your spiritual care providers, and your own skills to speak with patients about like how do you make sense of life, what matters to you, what are your values, can really help us to understand where their spiritual distress or spiritual health is coming from and how they're deciding what matters to them. And, you know, when you're at the bedside having those conversations, are we going to fix the systems? Not when you're in that room, no. But going the extra, like, uncomfortable distance to acknowledge this is your experience goes a long way towards affirming each person's inherent value and dignity. And like Molly's, your case so brilliantly illustrates, sometimes it takes a lot of work to show someone that they're just as important as the next person. Sometimes we have to do a lot of extra, you know, the picture of the ladder, and you know, I love that image, that sometimes it just takes more to remind people that they matter, that each individual matters. And when we do that, we may not, you know, the likelihood is that that young woman is no longer alive. But I certainly hope that she was able to be with her parents and experience that. She's a beloved child of her mother and father, whatever they, you know, everybody's family is complicated, but to experience that and to know that that mattered, it mattered to her and therefore it mattered to us. And so we're going to work very hard to make sure she has the chance to have that measure of peace that every human being deserves to have. You know, I think, I know we're kind of bumping up to our time, but I also think that whatever your personal spirituality or personal religious practice, I think when we come to this conversation, it can also be a source of strength and restoration for us. That, you know, when it feels like, gosh, there's some stuff that's just baked in that is going to be really tough to address and to weed out. But if we really cling to and are rooted in our sense of values and what is right and good to do, I think that will not only empower us to look at each individual and truly see them as mattering and good and worthy of having a chance to achieve peace and wholeness and wellness, but also it will give us the courage and the strength to continue to call out what is unjust and keep doing that until we've made our little bit of difference. And when we add up all of our little bits of difference, that adds up to a lot. So that's my little morning rousing speech, because I know these are big things. Thank you, Molly and Tori, for letting me piggyback on this conversation.
Absolutely. We need your perspective. You're right. Spirituality is different for everyone, and it still helps us get to the core of a person. Thank you. So in hearing this, you know, why is it important to address disparities? Well, we have just heard how disparities impact our patients and our health. So addressing these disparities in health and healthcare is important not only in an equity standpoint, but also for improving the nation's overall health and economic prosperity. It is increasingly important to address health disparities as the population continues to become more diverse. We'll have different income inequalities that will continue to grow that we need to champion for. And it is projected by the CDC that people of color will account for over 52% of the population by 2050, with the largest growth occurring among the people who identify as Asian or Hispanic. Quickly, you'll see here what the federal government has done to address disparities. The CMS, as we all know, the Center for Medicare and Medicaid Services, has released updated framework to help advance health equity, expand the coverage, and improve health outcomes for the patients covered by these insured. There have been growing federal efforts to address disparities in maternal health, and the administration and Congress has taken a range of actions to stabilize and increase health coverage in the pandemic, as well as addressing health disparities and discrimination experienced by the LGBTQ+ community. In the wake of COVID-19 pandemic, there has been a heightened awareness and focus on addressing health disparities. So let's take a minute to pause as we wrap up here. Let's reflect on what we've heard, not only the case example that Molly shared, but the patients that you've met this week. How have they been impacted by their social determinants of health? How has their health equity experience been? What does your healthcare system do to commit to improving health equity? Do you have a diversity, inclusion, equity team? Do you have someone that you can reach to learn more, to educate yourself? What can you as a team member do within your system to impact and improve the lives of your patients? Not only the patients we serve, but think also of our community. So let's start now in taking steps towards equitable care for everyone that we meet at our healthcare agency, as well as those that we encounter at the mall or at the store. Are we thinking of how our system is set up to have others disadvantaged? How can we change that? This diagram here is something that the CDC leadership team created in 2021 that starts to build efforts to address social determinants of health on a grand scale. These rings here indicate different frameworks, these pillars, they say, will help lead change when it comes to equity: policy and law, data and surveillance, evaluation and evidence building, partnership collaboration, community engagement, infrastructure, and capacity. We have to realize that it can start with us, the patient that we meet, that tree that we keep referring to. What can we do to understand our patients' values? What's important to them? How can we help identify and navigate and break down the barriers that impact their health? In conclusion, health inequities are on a historic level. These inequities have shaped the institutional and societal structures of our government, of our policy, of the norm here in the United States. We need to do our part to improve this, to improve our patients, to learn about their personal stories, explore our goals of care, their values, hopes, their dreams and fears. We need to do something on a system level and allow those that don't have a voice to have a voice, to help them feel safe and comfortable in having that voice with us. We can do better today. There is improvement that we can make even this week within ourselves, as well as understanding the patients that we serve. Health equity is something that should be discussed and advocated for every single day. Please know that the work that you do with your patients is so needed and much appreciated, and we can continue to do better every day. Thank you for allowing us as an interdisciplinary team to talk with you about health equity. As you can see, we are all very passionate about this, and it means so much to us to be able to share this with the team.
Thank you so much, Tori, Molly, Natasha, for just this excellent summary of literature, what's been just the history, and what next steps we can take just as individually, as a team, and health systems. And just a powerful example of that case is just just need another hour to just discuss that and dig deep. So I hope just in your different groups, wherever you are, that you can, talk with those around you, what impacted you from the case story, and maybe what steps something you may do different because of that, of what we've learned today. If there's any questions, we could want to give a space for that before we enter into the case time. Is there anyone who wants to ask any comments or questions?
Yeah, first of all, I just wanted to thank the three of you for a really outstanding talk. This is so important. And Molly, as you were telling the case, I just had little shivers because it took me back 40 plus years to a case that I had as a resident of a migrant worker up in Grant that was a young Hispanic woman with cancer. And this was, of course, before the days of EMRs and even before the resources we have now, and how difficult it was to navigate even at that time, even more so. And that even with what we have today, we still have 4 decades later these challenges. And it frightens me to know that this is happening every single day in every single health system here in the United States, particularly here in West Michigan, these types of things. And here's the fear that I have, and just as this is a challenge for those of you who have not yet signed up for the Trinity Health Palliative Care Conference on October 6th, I really encourage you to do that. And one of the most important things is to hear Dr. Simi Bey talk about inequities in healthcare, and more importantly, her discussion on implicit bias, because I think that underlies this. There are people in our healthcare systems that have this inherent either conscious or subconscious belief that that it's not that necessarily bad to discriminate, and it's extraordinarily distressing. But it happens all the time, and our insensitivity as a system to those types of things is what fosters these types of inequities. So anyway, I didn't have a question. I just wanted to thank you so much for presenting this and just to offer those comments.
Absolutely. Thank you.